Good evening, everyone. So, coming to the next webisode 2, continuing the decoding GI and HBP oncology. So, and in the continuum of the GEP-NET series, we welcome you all to the session 2, which is focusing on surgical management of metastatic GEP-NET. So, basically, by this surgical management of metastatic GEP-NET, hereby we want to focus where should we as a medical oncologist should know what is the domain of surgeons in that area, and should be more wiser to help the patients in that scenario. So I welcome you all, and taking note of much of your time, so I'll welcome Dr. Ishita, so who will be discussing on Theranostics of GEP-NET.
Thank you for having me here. Theranostics comes from two words. It comes from therapy and diagnostics. So theranostics has been used it's a very contemporary word. So it's a word which has got, which is now coming into vogue. And the reason for that is that you use the same target or the same molecule both for diagnostics as well as for therapy. So this is not just for nuclear medicine, although it is being used very rampantly in nuclear medicine practice, because we use the same molecule both for the diagnostics as well as the therapy of certain tumors like neuroendocrine tumors, like actually traditionally iodine was the first theranostic agent, because iodine is used not just for the diagnosis of thyroid cancer, but also in the treatment of thyroid cancer. But as things have proceeded, now there are various other molecules which are used both for diagnosis and therapy, and hence the word theranostics. It's also used in molecular medicine at where various targets focusing on various genes or various molecular processes are used both for diagnosis and therapy. So coming to my topic today, I've been asked to speak on the role of radionuclide imaging and therapy in neuroendocrine tumors. So I'm going to quickly run you through the role of radionuclide imaging as well as therapy in neuroendocrine tumors. And I think just to give you a beginning, as you all know, that neuroendocrine tumors are unique tumors because they can actually arise from any organ of the body. And they have some unique features because they have secretory granules which produce biogenic amines as well as secrete polypeptide hormones, and hence the word neuroendocrine. They are low incidence of neuroendocrine. They occupy less than 2% of all gastroenteric tumors, gastrointestinal tumors, out of all the gastrointestinal and bronchogenic tumors. The diagnosis of these tumors is difficult, mainly because they are low proliferation, they are often indolent, slow growing, and patient often presents with varying kind of presentations, right from having very small occult tumors to presenting with extensive metastatic disease. And they are also a very heterogeneous group of tumors. The behavior pattern varies depending on the organ from which it is arising, depending on the kind of hormone which it secretes, as well as on its proliferation index. So as such, it's a very enigmatic group of tumors, and that is why it's often been related to zebras. The neuroendocrine tumors are associated with zebras because they say that when you hear the pounding, it's not always horses, it could be zebras as well. Now, if you look at the typical cross-sectional imaging, this is a CT. So these patients present because there is a lot of desmoplastic reaction around these tumors. There is often shrinkage of the mesentery, and so you will often find the classical patient of neuroendocrine tumor will have a small primary somewhere in the intestine, and this is I'm talking about the GEP-NETs, and here they will often have a small lesion somewhere in a mural nodule, and the most characteristic finding would usually be a kind of a stellate mesenteric mass, which is a nodal mass, and with these typical desmoplastic reactions showing a shrinkage of the mesenteric fat around the lesion. There is often foci of calcification within these mesenteric masses. And if when you do a contrast enhanced study, there is usually a very intense delayed arterial phase enhancement of these tumors. When these patients have metastases to the liver, these tumors often will have cystic metastasis. So if you have arterial phase enhancing lesions in the liver with central cystic necrosis, you must always think of neuroendocrine tumors being a possibility. And often when you do a endoscopy, you will find these are usually submucosal lesions, and that's why unless you take a deep bite of the specimen, you will not get the tissue, because these are not mucosal lesions. So you have to basically cross the mucosa and go into the submucosal space. And often finding a primary neuroendocrine tumor is like looking for a needle in a haystack. And that is where probably these functional imaging, or what we now everybody calls it a DOTA-NOC scan or a DOTA scan. DOTA scan, I mean, just going off the track, when we often get requisitions for a DOTA scan. Now that is a misnomer. DOTA is a chelating agent. What you're looking for is an octreotide scan. So because the receptor which we are targeting are the somatostatin receptors, and what you're trying to do is a PET scan which actually uses a radio molecule which is targeting the somatostatin receptors or the octreotide receptors. So often when surgeons or physicians or gastroenterologists, they ask for a DOTA scan, it's a misnomer. You should ask for an octreotide PET scan, and that is the correct way of speaking it out. Now, most of these neuroendocrine tumors will express somatostatin receptors. Now, as you would know from your biochemistry days, there are typically 5, there are actually multiple, but there are 5 main somatostatin receptors, which are like SST1, 2, 3, 4, 5. And out of this, it is the SST2 and SST5 receptors, which are expressed in abundance in these neuroendocrine tumors. And these are the receptors which we target while doing our DOTA-NOC scans or the octreotide PET scans. Now, amongst all the different neuroendocrine tumors, usually there is almost a very homogeneous increased overexpression of somatostatin receptors. Almost 100% of gastrinomas will express somatostatin receptors, and it's usually the small cell lung cancers and the insulinomas which have a relatively less expression of somatostatin receptors. And that is the reason why when you have insulinomas, using a DOTA-NOC scan may not always pick up the insulinomas, and a GLP receptor is a better modality to look for insulinomas, or DOPA scans are better modalities to look for insulinomas rather than a DOTA-NOC octreotide scan. Similarly, for small cell lung cancer, because these are relatively poorly differentiated tumors as compared to the well-differentiated neuroendocrines, which you would see in the other scenes, FDG scan is usually a better modality. However, there are many small cell lung cancers which do express octreotide receptors, somatostatin receptors, and they may be targeted by a DOTA-NOC scan as well. Now, as I said, DOTA is a chelating agent. It chelates to the small peptide which targets the somatostatin receptor on one end and the radioactive substance to the other end. And the radioactive substance may be a gallium-68, which is a diagnostic agent, or it may be lutetium-177, which is a therapeutic agent. In the earlier days, we used to use indium-111, again both for diagnosis. You can label it with Y90, yttrium-90, which is again a therapeutic agent. And now you can label these with various alpha emitting agents like actinium. So some of you would have heard of alpha PRRT. So alpha PRRT is the next level of PRRT after beta PRRT, which is with lutetium, and we'll come to that towards the end of this talk. So DOTA is a chelating agent which attaches these two fragments of a radiomolecule. And these radiomolecules will usually have a very high binding affinity for the SSTR2 and SSTR5 receptors. Now, most of the centers which are doing work with neuroendocrine tumors will have something like, this is called a gallium generator. So this is usually an in-house generator which is present. And that is why with this gallium, unlike FDG, which is made in a cyclotron, the gallium-68 DOTANOC is usually made within the department using proper, good labeling practices and proper sterility and everything. And this is used for doing the scans for the neuroendocrine tumors. And of course, doing a somatostatin receptor PET-CT gives you the advantage of the high spatial resolution of a PET scan, along with the high specificity of a somatostatin receptor scan, which only accumulates at the in the tumors which are expressing somatostatin receptors. Now, this is a meta-analysis which was published way back in 2014, where they tried to see what was the pooled sensitivity and specificity of somatostatin receptor PET, and they found that whether you use gallium-68, there are various peptides which can be used. So you'll have these fancy names called TOC, NOC, TATE. So these are different peptides, but across the board, the sensitivity, the pooled sensitivity and specificity of these radiopeptides for detecting neuroendocrine tumors was very high, with a sensitivity of almost 93% and a pooled specificity ranging from 85 to even 100%. So what are the indications for which you would order a somatostatin receptor PET scan? So typically, the indications which you see in your clinic are when a patient comes with a carcinoid syndrome, comes with flushing, diarrhea, incessant secretory diarrhea, or or any of the other syndromes, whether it is because of hypersecretion of vasointestinal peptide, or because of increased secretion of glucagon, or hypoglycemia, or increased serotonin. So it again, the symptomatology of the patient depends on the hormone which is secreted in excess. However, almost 80% of neuroendocrine tumors are non-functional. So these are the tumors which come, which grow, which are if indolent, they often present with extensive metastatic disease, and the patient is largely asymptomatic till he comes with either pain in the abdomen or multiple lesions in the liver, which are detected incidentally while an ultrasound or a CT is done for the diagnosis of some other issue, or the patient comes with a dragging sensation in the liver because of the large tumor burden, or comes with features of intestinal obstruction, because these tumors in the small intestine are often, they cause intussusception and they cause symptoms of intestinal obstruction. So these are typically the scenarios where the patient will present to you in your clinic and you order for a DOTANOC PET-CT where you suspect that there is a carcinoid syndrome or the patient has a neuroendocrine tumor. Also, in situations where you've got a tissue diagnosis that the patient has got a metastatic neuroendocrine tumor and you're trying to look for the primary so that you can decide how and what modality to use to treat this patient, again, a DOTANOC scan may help you. The extent of disease scan, then decision regarding appropriateness of PRRT or of chemotherapy, depending on what we are looking at, and of course in response evaluation. So these are typically the indications for which DOTANOC scan is ordered. So just to show you some of these indications, I've got just 4 or 5 very short cases. So this was a 68-year-old gentleman who landed up in a doctor's clinic in North Delhi with incessant secretory diarrhea, which was to the range of about 6 liters per day. Was extensively worked up with upper GI, lower GI, capsule endoscopy, US. Nothing was found. He was on PPIs, and hence chromogranin could not be done as it was unreliable in the setting. And when we did a Dotanoc PET scan, you find that there is a small lesion. So this was a VIPoma, which was in the second part of the duodenum. And this was subsequently resected, and the patient was absolutely fine. So again, you can see this so beautifully, such a tiny lesion, but you can see because of the overexpression of the somatostatin receptors, you can see it shining so beautifully. And this lesion, if you take away the functional aspect, if you just look at the triple phase CT or the arterial phase CT, unless you're actually looking for a tumor out here, you would miss it. So again, this is the beauty of having functional imaging, where a lesion, when you go back and look at it, you will often find it, but upfront these are lesions which will often be missed. Now this patient underwent a relook EUS and had a small tumor in the first part of the duodenum in the lateral wall, underwent resection, and the final histopathology was a well differentiated NET with a Ki67 of 1 to 2%. Second case, a 40-year-old lady who presented with mild abdominal discomfort for last 6 months. On ultrasound, there were multiple cystic lesions in the liver. Patient was well preserved. Serum chromogranin level was high. Biopsy from the liver lesion showed metastatic NET with a low Ki67. And here you find that this is a patient who's got these 2 large lesions in the right lobe. And on the scan, you have another lesion in the duodenum, again this time in the second part of the duodenum, and this patient subsequently underwent a resection of this duodenal lesion and a right hepatectomy, and was actually cured of the disease, and had a very till the time that we followed up the patient, she did not have any recurrence of her problem. So again, detecting the primary becomes
Dr. Ishita, sorry to interrupt you. Yeah. Can we wind up little quickly?
Yeah, sure.
Yeah.
So
all right. Okay.
Yeah, right. So this is a third case. Again, a patient with 2 malignancies, had a HCC and raised chromogranin, and interestingly, an FNAC from one of the lymph nodes showed a neuroendocrine tumor. And here we found that the patient had multiple lesions in the pancreas, which were showing increased somatostatin receptor positivity. And these were multiple. So you can see that often pancreatic patients will have multiple lesions in the pancreas in the same patient. So the diagnosis, of course, at the end of it was 2 malignancies. Patient subsequently was treated for both of them. This is the last scenario where you have a patient who presents with extensive liver metastasis. This patient was actually being worked up for a liver transplant. And there we found that the primary was in the periampullary region, but we also found a skeletal metastasis. And again, this patient then was subsequently did not undergo a liver transplant because of the extrahepatic disease. A patient where you are trying to look for a recurrence, there also a somatostatin receptor PET can be helpful. Now, when you look at the uptake of somatostatin receptors or the Dotanoc uptake, there is a Krenning score. So every uptake is not considered to be significant. Typically, the uptake which is at least more than that of liver, less than or equal to liver, is not considered to be significant. So it has to be at least the uptake in a particular lesion should be at least equal to that of liver. And the higher the uptake, the more chances of it of being a well-differentiated neuroendocrine tumor. And based on this, now there is something called an SSTR RADS. And while we will not go into the details of this, it is important for you also, when you look at a somatostatin receptor PET scan, to assess what is the uptake level of the Dotanoc, so that that actually guides you as to your accuracy of detecting a well differentiated neuroendocrine tumor. And in many endocrine tumors, there is a flip-flop phenomenon. So the more poorer the differentiation, the lesser the uptake of somatostatin receptors, more the uptake of FDG. So in a poorly differentiated neuroendocrine tumor where your Ki67 is more than 30%, often an FDG scan or a regular PET scan is more useful than doing a Dotanoc scan. And this is the flip-flop phenomenon. And as we go from G1 to G3 tumors, the G3 tumors are typically FDG positive, whereas the G1 and G2 tumors are positive on the octoscan. And here you can actually image this inverse flip-flop phenomenon where you have a patient who's got the FDG positive and Dotanoc negative neuroendocrine tumor. So this is again a poorly differentiated neuroendocrine tumor. Now, within a particular patient, you can also have a heterogeneity. So there may be some parts of the tumor which are well differentiated, while some which are poorly differentiated. And often a combination of FDG PET and a Dotanoc scan may be useful for actually detecting the worst differentiated, because your treatment will depend on that. So a patient who's got a significant component of a poorly differentiated tumor is not going to respond to PRRT, or is more likely to fail PRRT than a patient who's got predominantly well differentiated. And so based on this, you have something called a net PET score. So with the net PET score, you actually see whether this patient is appropriate for a PRRT, which is the therapeutic part of the neuroendocrine tumor theranostics. And so patients who've got a very high discordance between the somatostatin receptor positivity and the FDG positivity, with more tumors being FDG positive, are less likely to respond to a somatostatin receptor based theranostic therapy like PRRT. So just the last couple of slides on PRRT. PRRT is nothing but the therapeutic part of this theranostics. And here we use the same somatostatin receptor target to deliver destructive radiation to the cancer cells by the use of certain radiolabeled peptides, which specifically bind to the peptide receptors which are expressed on these tumor cell membranes. And PRRT is used in the treatment of metastatic or unresectable cancers of neuroendocrine origin, and they may be given either systemically or more occasionally by a locoregional or an intra-arterial administration. Now, unlike, if you remember the slides from before, where the diagnostic scan usually looks at the SST2, the SST2 and SST5 receptors. Here we basically look at the SST2 receptors, and you can label it with various particles: the beta particles, which is the most commonly used particle, which is the lutetium, which is used in PRRT, and the alpha particles, which are the actinium or the bismuth, which are now being used more frequently in patients of neuroendocrine tumor. So the indications, of course, it is used in well-differentiated and moderately differentiated neuroendocrine tumors, and it's used in patients with a positive expression of somatostatin receptors, as well as those which are metastatic or inoperable, and usually in patients who've got a large volume disease and who have progressive disease. So the intent to treat has to be very clear, and usually patients who are treated should have a progressive disease or should have a large volume disease. Sometimes it is used in patients who failed some sandostatin. So now NCCN says that you can use PRRT even as a first line therapy in patients who've got a large volume disease. And earlier it was only approved for second line in pancreatic neuroendocrine tumors. However, now there is a growing evidence that it can be used as a first line, especially in patients who've got a large volume, well differentiated neuroendocrine tumor. And this was the NETTER-2 trial, which was the trial which actually got the FDA approval for PRRT and brought it to the mainstay. And this was multicentric phase 3 randomized clinical trial which had two arms. One arm, the patient was on octreotide LAR 60 milligram, and on the other arm, the patient was on octreotide plus PRRT. And they found both the objective response rate as well as the progression-free survival. There was a significant benefit in the PRRT arm, and this was the study which actually brought the PRRT FDA approval. And this is one of our patients. Here you can see this was a patient with a extensive metastatic skeletal disease, and post 6 cycles of lutetium, you find that the patient is in almost a complete response. And more importantly, there is a significant improvement in the quality of life. So this was also looked at in various other studies, where it is not just the progression-free survival or the objective response rates, but also the quality of life, which improved with patients on PRRT. Now, there are various other ways of improving PRRT. There are now newer peptides. You can use therapy with lutetium and yttrium-90. You can administer the PRRT intra-arterially into the hepatic artery to improve the first pass extraction. So this becomes very important, especially in patients who've got a liver-dominant metastatic disease. You can combine it with targeted chemotherapy like capecitabine and temozolomide, and then it is called PRCRT, and this is especially important in patients who've got intermediate grade neuroendocrine tumor or a slightly higher grade neuroendocrine tumor, and especially in pancreatic neuroendocrine tumors. And of course, in patients who fail lutetium PRRT, you can use alpha PRRT or actinium labeled PRRT. So this just to summarize everything. So we've gone beyond lesion counting, and now we are at lesion characterization. And we can actually, this is a true use of personalized medicine. Thank you.
Yeah, thank you, Dr.
All right, thank you
Ishita.
so much. Yeah.
Thank you very much. So we have a couple of questions here. Dr. Jaspriya has asked, what's the maximum number of cycles for PRRT, lutetium PRRT, which we can go for if the patient is responding or remains stable? And she has also asked how significant marrow suppression is seen post PRRT.
So I think Jaspriya is as competent as I am to answer this question.
It's probably for the benefit of students.
Yeah, for the benefit of the students. There is no such criteria that you can give only so many cycles of PRRT. So earlier, we used to typically give 4 cycles of PRRT at intervals of about 3 months. There are some centers which give 6 cycles of PRRT at intervals of 2 months. There are also some centers, but now, as we have learned from the last 20 years of PRRT, the trend is going towards giving less. So there is earlier we used to say that there was a 1% risk of myelodysplastic syndrome with PRRT, but now we know that the risk is probably more, somewhere around in the range of about 10 to 12% risk of myelodysplasia with PRRT, especially in patients who also received alkylating chemotherapy. So the trend is to try and reduce the number of cycles while trying to improve the quality of the PRRT. So this can be done either by administering the tracer intra-arterially, where the first pass extraction of the PRRT makes the PRRT more efficient, or in using newer peptides where the affinity of these peptides for the receptors is higher. So in our center, we have now where we are combining PRRT with targeted chemotherapy. We give only 2 doses of PRRT, and we give it intra-arterially. And then the attempt in most of these patients is just to stabilize the disease. It is not, we cannot cure this disease. So there is no point in, giving cycle after cycle after cycle of PRRT in an attempt to achieve radiological CR. The attempt is to stabilize the disease, give a good quality of life, and hold on to the number of cycles so that you can use them when the patient relapses. So that is,
Yeah.
so the different regimes. So there's no one fixed rule that you have to give this many, but there are pros and cons of each of these. So we can have a discussion on that at some other point.
Yeah. Thank you, ma'am. So I'll quickly ask Manish to take over, and I'll also quickly introduce the panel. So Dr. Puneet Dhar, Dr. Manish is our dear colleague, and he is a very nice laparoscopic surgeon. Dr. Puneet Dhar is professor and head of GI surgery at AIIMS Rishikesh. We have Dr. Vivek Mangla, who is associate director of GI surgical oncology at Max Vaishali and Max Patparganj. Then we have Dr. Lovkesh Anand, who's a gastroenterologist at Manipal Hospitals. We have Dr. Amrendra Amar, a medical oncologist from Patna. And then we have Dr. Pankaj Baweja, who's a histopathologist with Apollo Hospitals.
All neuroendocrine tumors are potentially malignant. So initially, like, there is also thinking that neuroendocrine tumors are indolent tumors. Yes, they are indolent tumors, but they are also potentially malignant, whether they are grade 1 or grade 2 or grade 3. And once they are malignant, the prognosis changes. So they are even characterized as neuroendocrine neoplasms. So liver is the predominant site of metastasis other than the localized lymph nodes. And up to 75% of the patients with small bowel neuroendocrine tumors, and up to 85%, 30 to 85% of pancreatic neuroendocrine tumors can present with liver metastasis either at initial evaluation or during the course of their disease. And two large population-based studies have shown that up to 12.9% of patients already had liver metastasis at initial diagnosis, regardless of tumor location. And 10% of neuroendocrine tumors have liver metastasis with unknown primary at presentation. This is another problem. So how do we actually classify these liver metastases? This classification is taken from European Neuroendocrine Tumor Society, and they have classified liver metastasis in three groups, three types. Type 1 is single metastasis. Type 2 is isolated metastatic in one lobe of the liver with smaller deposits in other lobe. And type 3 is the disseminated metastasis. So in this webisode, we will have panel discussion only about type 1 and type 2, where actually surgeons have role. And type 3 disseminated metastasis will be having a separate webisode, that will be third webisode on neuroendocrine tumor. So this is so let me start with our first case. So this 54-year-old gentleman, he presented with the complaints of pain, upper abdomen, weak complaints of pain, upper abdomen with recurrent symptoms of hypoglycemia. So what he told was like he was having some symptom hypoglycemia, and he documented also that at the time of hypoglycemia, blood sugar levels was 60, which he took actually at which was taken outside. And he was not a diabetic patient, so he was not taking any oral hypoglycemic agents or insulin. And CT was also done outside, which was suggestive of large lesion in right lobe of liver. Some features were suspected of neuroendocrine tumor. So Dr. Lovkesh, who is gastroenterologist with us on the panel, I would like to ask you, like, these patients usually come to gastroenterologists first. How would you like to investigate these patients?
So as we can see, the patient is now, he has come to you with hypoglycemia. So first he follows whether he fulfills the criteria of the Whipple's triad. So which is the patients having hypoglycemia with the neuroglycopenic symptoms, and the symptoms are corrected with the administration of glucose. So this is the characteristic triad. So, but only, and for detection of insulinema, we need to evaluate the level of insulin at the time of this thing. So, if the insulin level is more than 6 MCIU per liter, then we say that it is insulinoma. But it is also seen that the absolute level of insulin is not always raised. So there are certain other parameters, particularly the C-peptide level, the proinsulin levels, the ratios like the insulin and the glucose ratio. So the insulin glucose ratio more than 0.3, the C-peptide level more than 0.2, the proinsulin level more than 20. So these are other parameters which helps us diagnose the insulinoma. So what we do for the screening is the prolonged fasting test. Earlier, there was a 72 hours fast that was required, but now it was shown that even the 48 hours fast, that also triggers the symptoms and the values. So what we do practically is the patient is admitted, because it has to be done in the admitted patient.
Yes.
And every 4 hourly, we measure the glucose levels. When the glucose level goes less than 50, then we have to do it every hourly. And if the patient have symptoms, then we stop the fasting. We take out all the samples for the measurement of insulin, proinsulin, and C-peptide. And so it may happen in the overnight fast also. And depending on these criteria, we can diagnose that whether it is insulinoma or not.
Right, right. So patient actually presented with a CT films which was showing a lesion in the liver. And usually, as we know, that insulinomas are not metastatic. Usually they are not metastatic. They are indolent small tumors, usually located in the pancreas. And many times they are even not located on localized also. It is difficult to localize them also. So it is an unusual scenario where actually patient presented with liver metastasis, some liver lesion which is showing some functional secretions, some hormonal secretion which is leading to hypoglycemia. Maybe it is a progression of a neuroendocrine tumor with gain of function later on in the natural history, or it is a pure insulinoma which is metastatic. We don't know. So what next actually? So this patient underwent some blood investigation, serum chromogranin level which was high, 1050 serum insulin. So he also underwent fasting test as told by Dr. Lovkesh. So after 12 hours fast only, he had symptoms of hypoglycemia. The insulin level detected at that time was 3.5, which was not diagnostic of insulinoma, and blood sugar level was 60, but patient refused for further fasting. So anything means like above 6 is definitely diagnostic of insulinoma, but anything which is above 3 and lying between 3 and 6 is also gives some clues that that it is a functional tumor. So what next, Dr. Vivek Mangla? So how would you like, what will be your next investigation in these kind of patients actually?
So at this point in time, probably upper GI endoscopy, there are two ways of going about it. You could either do the endoscopy first, or you could do the Dotanok PET first. And either which way you do either of these two investigations, essentially the Dotanok PET, especially when you have a patient who's presented with a liver met, you're not really trying to localize the primary lesion right now. That is not the real aim right now. So first step would be to assess the extent of the disease in this patient. At the same time, if you're able to localize the primary, that would be good enough. And so at this point in time, probably as far as I am concerned, a Dotanok PET would be probably be the next investigation once we have had this kind of a patient, and then we would follow up with the rest of the investigations.
Okay, yes, it may sounds good actually. So so Dr. Ishita, you have already presented a very beautiful presentation on Dotanok PET. So I want to ask you one thing, like do you recommend dual tracer PET in all patients, or Dotanok PET will be your first choice of investigation if we are planning for octreotide scanning PET?
Dotanok scan is basically, in this particular situation, is you're trying to, it's an extent of disease. You already know that you have a metastatic lesion in the liver. So you're basically trying to look for the primary somewhere in the pancreas, or you're trying to see what is the extent of disease, which will change your management. So that's the purpose of the Dotanok scan here. The need for a Dotanok and an FDG together happens where either you have a biopsy which shows that the tumor grade is higher, or you're trying to, typically in patients where even on any one imaging, on a Dotanok scan, you see some heterogeneity. So you see some lesions which are not showing Dotanok avidity. Also, prior to any kind of therapeutic modality, especially in patients who've got, in a patient who's got a Ki67 of 1 or 2%, doing an FDG scan is probably not needed. But in patients who are intermediate grade neuroendocrine tumors, pancreatic neuroendocrine tumors, neuroendocrine tumors from the lung, so foregut tumors. So these are the tumors where there is a higher chance of it being aggressive. FDG PET basically detects the more aggressive component of the neuroendocrine tumor.
Yes.
So wherever you are suspecting that there is going to be an aggressive component, that is where you require an FDG PET.
Right. So basically, what you mean to say is that dual tracer PET-CT DOTANOC combining with FDG is not required in all the cases. Whenever our suspicion is high, then only we should order this. Otherwise, DOTANOC PET scan, particularly in functional tumors, but because they are more likely to be lower grade tumors.
Lower grade tumors.
So we can safely go with DOTANOC scan.
Manish, Dr. Puneet want to say something.
Yes.
I don't know. I got disconnected for a short time, so I don't know if it was taken up. But I think this is one of the few tumors, insulinoma, actually, which is less DOTA avid. So
yes.
I just want to. So I know since we are doing a NET seminar for everybody, it would be the next logical step. But insulinoma, we need to be aware, as Dr. Ishita said also, that it is actually the chance of picking up is much less because the 2 and 5 receptor affinity being less.
So he has shown in one of our slide that it is like 70% sensitivity is there, if I'm not wrong.
Yeah, as compared to 100 for gastronoma and all.
Yes,
so it's sometimes if you're not getting it particularly, it might be a good idea to even go ahead with a biopsy straight and establish the grade first. Then the other questions will become more valid. If it's a high grade, you might need to do dual tracer and all that.
Dual tracer.
There is also a tracer called exendin, which is a GLP receptor, which is used specifically for insulinomas. So gallium, just like you have gallium DOTANOC, you have gallium exendin, which actually is a more specific tracer, specially used for, it targets the GLP receptors. So it is very useful in neuroendocrine tumors. Also DOPA, fluorodopa, is something which can be used, and it is often used in patients of nesidioblastosis to differentiate between the focal and the diffuse nesidioblastosis, and also in patients of insulinomas, a DOPA scan may be worthwhile.
Okay, so moving forward, so it is always very difficult to define the exact pathway in which we have to go. We can go for biopsy also in these cases first, prove that they are neuroendocrine tumor and then go for DOTANOC, or we can have DOTANOC PET-CT first and then go for biopsy. So Dr. Pankaj, he's a pathologist, so I want to know, actually, most of the times when we see these patients in our clinics, they already underwent some kind of FNAC from the liver. So what is your recommendation for a role of biopsy versus FNAC when we are suspecting neuroendocrine tumors actually?
Actually, biopsy is always better, because the new WHO classification, as you have already told, that it has divided into basically two types: well differentiated and poorly differentiated. And accordingly, mitotic activity we have to count, and Ki-67 proliferative index should be used. Everything is not possible on the FNAC.
Yes.
So biopsy is always recommended.
So biopsy is regarding biopsy, biopsy is essential in metastatic neuroendocrine tumor. Unlike non-metastatic, if we have like single lesion in like in last episode we discussed non-metastatic single lesion in pancreatic head looking like neuroendocrine tumor on imaging, we can straight away go for surgery. But in metastatic neuroendocrine tumor, it is essential because we have to determine the grade of the neuroendocrine tumor. Second thing is biopsy is always preferred over FNAC for grading purpose. And biopsy from metastatic site is essential if PET shows heterogeneous lesions on DOTANOC and FDG PET. So in these cases, we try to take biopsy from FDG avid areas because they are more likely to be higher grade lesions.
So I had a query.
So Dr. Pankaj, for the students, can you please just summarize how do we grade these tumors? What is the recent changes in the grading of these neuroendocrine tumors?
Yeah, as per latest WHO 2019, it is basically divided into two subtypes: well differentiated and poorly differentiated. Well differentiated is further subdivided into grade 1, grade 2 and grade 3, and accordingly mitotic rates in grade 1 is less than 2 with a Ki of less than 3%. Grade 2 it is between 2 to 20 mitotic index, and Ki-67 is 3 to 20, and grade 3 NET, which are well differentiated grade 3 NET, poorly differentiated small cell type or large cell type. All these three subtypes will show same mitotic activity, which is more than 20 per 10 HiPA field, and Ki67 index of more than 20%.
Okay.
And the basic differentiation is again shown in the lower table. It is well differentiated and poorly differentiated, depending upon the morphology. Well differentiated, as the name suggests, a good looking tumor with not so much necrosis, insular or trabecular pattern with a medium sized cell nuclei and round nucleus without nucleoli. But poorly differentiated, as the name suggests, a bad looking tumor with abundant necrosis most of the time and high NC ratio cells with prominent nucleoli.
Yes. So one more thing I would like to know is, like, can we actually, do we need to do IHC in all the cases, or can we morphologically only we can make the diagnosis of neuroendocrine tumors?
IHC is always a must, because morphological differentials are always there, like lymphomas. Morphologically, the neuroendocrine tumors look like a round blue cell tumor, and round blue cell tumor always has a differential of lymphoma,
Yes.
melanoma, rhabdosarcomas. Many differentials are there depending upon the site. So IHC is a must, and IHC also I would like to highlight one important point. A panel should be done of at least 4 markers consisting of synaptophysin, chromogranin, NSC, and CD56 should also be included, because most of the time if pathologist performs one IHC, only synapto or chromo, especially in high grade tumors, the loss of IHC of synapto and chromo has been seen. So in that cases, CD56 and NSC patchy positivity and in the background of clinical scenario, it may help. So always a panel should be done of at least 4 markers, and it should be labeled as a neuroendocrine tumor if at least 2 markers are positive.
Okay, thank you very much. So this patient Dotanok PET was done, which showed one large lesion in segment 8 and one smaller lesion, if you can see, in segment 6, with a small primary in the duodenum at the junction of D2 and D3. Upper GI endoscopy was done, which was normal, because maybe the evaluation was not very perfect. So Dr. Lovkesh, is there any role of endoscopic ultrasound in these patients to detect primary if endoscopic upper GI endoscopy is normal?
Yeah, definitely. So endoscopic ultrasound is now the best diagnostic modality for detecting the neuroendocrine tumors. Of course, in case of evaluation of the unknown primary, in case of metastatic this neuroendocrine tumors, we have to go for this upper endoscopy, colonoscopy in all the cases. And if in case of pancreatic, if we are suspecting, and then endoscopic ultrasound, it can identify the unknown lesions. And this ultrasound also has a role, like if we have detected the regional metastasis of staging and breeding, also it has a role. So definitely it's in this setting.
So in this case, we were able to detect primary by Dotanok PET, which is in the duodenum. So Dr. Puneet, I would like to know from you, what is the how will you manage this case? What is the role of surgery in such kind of patients where patient has like functional neuroendocrine tumor with limited liver metastasis?
So I think first things first, like we said earlier, that only 72% of the DOTA might pick it up. So first role is actually it could be diagnostic as well. So the accuracy of picking up on intraoperative ultrasound is even higher than EUS and DOTA. So if you're not getting the primary in the DOTA or the pre-op imaging, surgery in an insulinoma and for all the other nets also, which tend to be multiple, it's important to do a complete exposure of the pancreas and palpate it. Digital palpation alone can pick up about 90% of all insulinomas, which is again better than EUS as well. and the addition of intraoperative ultrasound makes it almost 99%. So it's better than it. Unlike all the other non-insulinoma neuroendocrine tumors where DOTA is better. So just to say that sometimes if you have a typical Whipple triad or the typical insulin glucose ratio, surgery can be diagnostic in picking up the primary as well. I mean, this is just because we've this particular case we started with the
sometimes there are more than one primary actually. So intraoperative ultrasound and digital palpation of the pancreas is must. So what factors actually determine the management of such cases?
So, I mean, since you outlined about the biopsy also, I think it's important to realize that the primary and the secondary may have separate different grades. So again, it's probably we are always looking for the most aggressive part. So if we have to biopsy, it should be from the secondary, Lovkesh would love to do a EUS guided biopsy, but here probably what would be even more illustrative would be the liver biopsy, which the grading from there. Even there it can be heterogeneous, but that would be better. So you've, I think, outlined the factors influencing the treatment. Right. Clearly, non-functioning tend to be worse, but some gastrinomas and all can be even worse than that. Grading, of course, the pathological grading is the single most important, and that's by the Chi-67 or the mitotic index if the MIB labeling is not available. Site and status again, some of the locations tend to be a worse outcome. Then the type of liver metastasis which you showed, some of which you're probably not discussing today, but again, those are factors which influence treatment.
Right. And other than that, what are the expertise and availability of therapeutic modalities which are there at the institute? Sometimes cost also we have to take into consideration, and quality of life of the patient after extensive surgeries. So what additional workup is required for planning of liver resection in such kind of cases? Dr. Puneet.
Yeah, so right. So, of course, we need to know what is the effective liver volume which is going to stay back after we've resected it. So CT volumetry is the most commonly done. ICG retention has been used particularly in the East, in the Orient. We are only, we didn't have access to ICG here, so it was not a very popular thing in India. But again, it could give you an idea about the functional liver status of the entire liver actually. But the volumetry will tell us the anatomy at least. So we don't really know but the combination can tell you anat and physio bit. Cardiac evaluation is important for many neuroendocrine tumors because you can have, there might be cardiac issues. Portal hypertension is also a very bad prognostic marker for, so an endoscopy when, I would request whenever Lovkesh is doing the endoscopy to look for the varices as well as that time, because that's a bad prognostic marker for any liver metastasis. Even transplant may be contraindicated, whereas it's an indication otherwise. Of course, specific perioperative treatment, you correct the sugar as much as possible. Somatostatin analogs, again, for the same reason of receptor affinity, they're not as useful as they are in other functional tumors, but we should always give it a try. And diazoxide is invariably better than that. For sometimes we need this for perioperative control, but usually just sugar is good enough to maintain them on good.
Usually in patients of insulinoma, they recommend is strict blood sugar monitoring, and we can start even a dextrose drip prior to surgery and then stop the dextrose drip just before surgery for proper monitoring of insulin as well as blood sugar level after enucleation, because they have increased after the enucleation. They have immediate change in the blood sugar levels also. So CT volumetry is very important whenever we are we have to keep this in mind whenever we are getting a PET CT done, because most of the time at most of the centers actually we come across a patient carrying the report of PET CT, but most of the time they are doing PET with non-contrast CT. So if we are ordering the PET CT, then we can write PET CT contrast so that anatomical location of the lesion also can be done, and we don't have to repeat another CT for CT volumetry. ICG retention test, again, Dr. Puneet has told, if facilities are available, but these tumors are usually not in CLD patients. So if liver appears to be normal on CT, then it is not required always. Cardiac evaluation is must. So what is your take on simultaneous resection versus staged resection if quantum of surgery is very high? So do you always recommend simultaneous resection, or stage resections can be done in functional tumors?
So the answer is easier, I think, for the insulinoma, because they tend to be single and is easily enucleatable. But the same thing if we extend it to other neuroendocrine tumors, non-insulinomatous tumors, where we need to do a regional resection, there this question is probably more valid. So here it's easier because if you see the bulk of the tumor production, the functional hormone production would be actually from the liver, given the size. So and the fact that it's picked up on DOTA, so it would be a functional rather necrotic liver. So we need, for the functional control, the liver resection in this particular case would be more important. In other cases, it could be different. So I think your DOTA will give you some idea about that, which is more appropriate. But anatomically speaking, the bulk-wise, this would be more important. For insulinoma, we can add on the enucleation. And ideally, sometimes you actually find even lymph nodes which pick up the DOTA in insulinoma. So you might need to do a radical, even a Whipple's kind of a situation. So if the patient is not a fit candidate for a combined, you can actually stage it by seeing which is the higher volume, so that you get a better functional outcome.
Yes. So what is the role of debulking surgery in these kind of patients?
So debulking is, I think, a very important concept in all functional tumors, because there's definite. In insulinoma in general, it tends to be non-malignant, as you said. But if it is metastatic, it's extremely useful, because bringing it down to a critical level, even though it's metastatic, they tend to be much slower growing than most other tumors. So you're going to get a long term of palliation before the tumor regrows. But for the other functional tumors, it's I think a combination of the grade as well. So we've got a lot of papers which show that 90% of tumor removed is going to give you a very good palliation and even longevity. But the unfortunate thing is we don't know. We don't have controlled data to show that if you hadn't done this, what would there be? What their lifespan would be? And we have other papers showing that actually very high-grade tumors, even if you debulk, they may not be of use. But yes, there's certainly a role in functional tumors where debilitating symptoms can be actually controlled, at least 90% if we can do it.
So, Dr. Vivek, is there any role of other liver ablative therapies which can be combined with surgery, or they can be used alone if surgery is not possible?
Thank you, Dr. Manish. I think I'll just go back to the previous thing. I think the most important thing that we have to understand about debulking is the fact that debulking will give you a reduction in tumor bulk, and in functioning tumors, reduction in hormone production, the most fastest of any other modality that we have with us. So that is an extremely important factor that we have to understand, and that is why the role of debulking. The second important fact that we have to consider as well is the fact that there is some evidence, and more so in functioning tumors. And I think there we have to understand that when we are talking of a G3 tumor and then we are talking about a functioning tumor, very few G3 tumors would actually be causing some kind of a functional functioning they would be having some syndrome of because of hormonal overproduction. So when we are talking of functioning tumors, they would generally not be G3. And therefore, in these tumors, probably sticking to that 90%, even if, as Dr. Puneet also said, you're able to debulk, say, 70% of the tumors. There is some data to that as well, which says that not just the symptoms, the longevity also improves, although not as much as 90% debulking. Now, coming to ablative therapies, yes, if you have, say, for example, insulinoma and in a difficult patient, a difficult location to resect, and RFA could be a good alternative to resection in these patients, which could be done intraoperatively at the same time that the enucleation or a formal resection is being done for the insulinoma. We honestly do not have I don't have any experience of downstaging with TACE for a neuroendocrine tumor where we've gone ahead and downstaging. Probably you could you put that point forth. You could actually elaborate on that yourself.
Right. So most of the time, intraoperative RFAs is used with liver resection if it is like type 2 kind of metastatic disease, where there is a dominant metastasis in one lobe and some deep-seated lesions in the contralateral lobe. And transarterial embolizations also, if for the liver, if it is patient is inoperable, or it is means if the volume of the liver is not the remnant volume is not enough, so then these modalities can be used. The papers are there. We have literature for these papers. So this patient underwent excision of duodenal tumor, which was located by manual palpation D2 and D3 junction, lymphadenectomy, segment 8 excision, liver metastasis from segment 6, and histopathology was grade 2 neuroendocrine tumor with key index of 4%. So, Dr. Amrinder, suppose if this patient is inoperable, like this patient is, the lesions are definitely resectable, but sometimes we come across inoperability because of poor general condition of patient or poor PS. So in these cases, what will be your, or what are your options actually as a medical oncologist?
Yeah, that is a long list to provide the patient. I mean, that is a long list of medicines to give to the patient. And I think as far as any evidence is concerned, we have very less evidence in context of all these, particularly if we take somatostatin analogs, we had PROMIT data, then everolimus, Radiant 3 was for pancreatic neuroendocrine, and thereafter Radiant 4 was for other midgut tumors also, and also for lung. And similarly, as Dr. Ishita said and Dr. Vivek said, PRRT, I think PRRT, we have some data about PRRT which says that, okay, the symptom control is better with PRRT, and as rightly said by Dr. Mangla, it is the symptom control and it is the bulk, disease bulk control which matters the most. So, but as you said, if it is a poor performance status patient, and if we use everolimus is fraught with many side effects, and one of these is pneumonitis, the others are rashes. And although everolimus has been found to be good in insulinoma, because everolimus also causes hyperglycemia. So I think all these options are okay, but given that the patient is having poor performance status, and I have seen everolimus at a dose of 10 milligram is rarely tolerated by patients. So in fact, we give many a times 5 mg and sometimes also 2.5 mg. So it's not that easily tolerable drug. And coming to PRRT also, I think if it is a poor performance status patient, I don't think he or she is going to tolerate PRRT that well. The more will be told by Dr. Ishita, but I think we can go ahead with somatostatin analogs as far as tolerability and acceptability is concerned. But of course, the effect will be lesser than that of everolimus and PRRT.
Right. So Dr. Ishita, is like, what is your means take on functional control with PRRT in these cases?
Can I just
Dr. Puneet
mention
has
one?
to say something. Yeah.
Yes,
Yeah. Can I just mention one more agent which unfortunately has become an orphan, but since it's an insulinoma case, and that is streptozotocin.
Yes.
Unfortunately, we've had a problem with availability in India intermittently because it's a very cheap drug. But for a resource-constrained country like ours, I think our medical oncologists need to push it as compared to much more expensive drugs as well. So that has also got a very good control. And I've heard many oncologists say that it's got side effects. I think everolimus can match side effects for that. So it's also a useful drug. So I think the kids should know about it, that if and when it's available, that's also an option for insulinomas, only for insulinomas. All the others are for all the other nets as well.
Okay.
I think the symptom control with PRRT is better than that with the somatostatin analogs, and that is it is. I think there are now numerous papers on that. Both not all of them randomized, but yes, there is a significant amount of at least phase 2 data which compares the symptom control of PRRT versus the somatostatin analogs. Having said that, so in patients with functional neuroendocrine tumors, we often continue the somatostatin analogs along with the PRRT, because there may be an initial flare of symptoms with PRRT, and usually the somatostatin analogs will help in tiding over that period. There used to be a lot of talk in the past about that if you continue somatostatin analogs, or if you continue octreotide LAR along with PRRT, the efficacy of PRRT goes down. So now that has been proven wrong, and they say in fact that there is a sync phenomenon by which the non-specific receptors, they get blocked by use of somatostatin analogs. So the targeting becomes better, and your response rates with PRRT become better if you are using it in combination with somatostatin analogs. So often in patients with functional neuroendocrines, we will continue with the somatostatin analogs while giving PRRT.
Right. So this patient is having DOTA-NOC avidity. So maybe it is more responsive to PRRT or somatostatin analogs. So coming to the case 2. So this patient is a 50-year-old gentleman. He was evaluated outside for symptoms of regurgitation of food, long-standing regurgitation of food. Upper GI endoscopy was done. It was a large esophageal diverticulum in lower esophagus. CT, chest and upper abdomen was done, which showed 2 hypodense lesions in liver. Biopsy was done outside, which showed grade 1 neuroendocrine tumor. We reviewed the biopsy here, which again showed grade 1 neuroendocrine tumor, and serum chromogranin level was raised 1161. So this was the DOTA-NOC PET, which was done in this patient, which showed a primary lesion in duodenum again at the junction of D2 and D3. So exact localization was difficult. Along with that, there were lymph nodes also, and there were 2 lesions in the liver. One was in the segment 7 and 8 junction, and other was in the caudate lobe behind the IVC. So Dr. Vivek, this case is different from the previous one. Like it is again grade 1 neuroendocrine tumor, which is detected in young, fit, healthy person which is completely asymptomatic. So it is an incidental detection of metastatic neuroendocrine tumor. So does resection benefits these patients?
Basically, when we are talking of a patient who's got so essentially, to summarize this, essentially is a patient who's got a non-functioning tumor.
Yes.
And probably this patient presented with symptoms which are totally unrelated to what has been found in this patient.
Right.
So given this scenario, at this point in time, a lot would probably be depend on what the patient's performance status is, as we talk about all the factors, some of the factors we have already mentioned here. So now if we go by the guidelines for these patients, if the patient is asymptomatic and the disease burden is low,
Yes.
that becomes the specifics of the situation. Yes. In this particular patients, the options are many, and the option would actually depend on what is the patient's performance status, fitness for surgery, what is the patient willing for. The options include just observation. The option goes on to include surgery, resecting the primary, maybe ablating the posterior place lesion, or maybe taking out the caudate lobe lesion if it is easily accessible, to a combination of resection and ablation to systemic therapy. So practically speaking, in this patient, all the options are on table. And as far as survival benefit is concerned, we have some data which suggests that there could be survival benefit of resection in these patients, but then lots of these studies have a lot of bias in favor of in the terms of the fact that these are very, very carefully selected patients who've undergone resection. Sometimes there would be patients who would have just an incidentally detected metastatic lesion intraoperative, which would have been resected. And when you look down at that, the survival benefit keeps on diminishing down. So somewhere along the line here, a lot of things will depend on how the patient is, and that's where you'll put in the resection somewhere in the picture.
So rightly said that neuroendocrine tumors are traditionally considered as indolent tumors, and they are actually indolent till they throw liver mets. But whenever liver mets are there, the prognosis changes. And untreated, what literature says is that untreated neuroendocrine neoplasm with liver mets, 5-year survival ranges from 13 to 54%. With no liver mets, 5-year survival is higher. So it means, so different societies have recommendation on this. particularly for non-functional neuroendocrine tumors with liver metastasis. They say that if it is resectable, should be resected. And the benefit of surgical resection for neuroendocrine neoplasm with liver mets have been demonstrated in terms of overall survival and quality of life. We have to balance the things like what quality of life we are giving to a patient and how much he is fit for any kind of major surgery. But definitely there is an overall survival benefit if we can achieve R0 resection in these kind of patients. So coming to, so this patient underwent surgery, Whipple's pancreaticoduodenectomy with the liver metastectomy with transhiatal esophageal diverticulectomy because he was symptomatic for that. So Dr. Lovkesh, so it was in this patient particularly, there was difficulty in locating the primary tumor. So we took the help of gastroenterologist also for intraoperative endoscopy. So would you like to tell us about intraoperative endoscopy and trans-illumination tests which we do like in these kind of patients to detect primary?
Yeah, in certain cases, where although it is rare that the lesion was found out in this rota PET and it was not seen on the endoscopy because the duodenal lesions are usually found. But yeah, if it is not seen, then combining the laparoscopy and endoscopy, this helps the surgeons because we can localize the lesion. So the transillumination, as you have rightly said, that it is done during the endoscopy and they localize so that they can reduce the extent of the surgical resection, because if it is not completely localized, the burden of the tumor resection would be quite high. So with this technique, we can identify, we can help the surgeon so that they can reduce it and the resection can be minimized.
Right. So this is one of the modality which we also use, but it was not detected on intraoperative endoscopy also. So intraoperative ultrasound was used as mentioned by Dr. Puneet earlier, and the lesion was detected, a small lesion was detected in head of the pancreas. So that's why patient underwent Whipple's. So Dr. Vivek, now coming to you again. So what is the role of debulking in these non-functional tumors?
Already discussed, when you come down to debulking in non-functioning tumors, we essentially have to see what we are looking at. If the symptomatic primary, if there is a primary which is causing symptoms and which can help take off the control of the local symptoms. And yes, as regards survival benefit of debulking surgery is concerned, more so in non-functioning tumors, we have to understand this fact that most of these studies, although there is some evidence that even beyond the selection bias, the surgery helps improve survival in these patients, but that would be on a case-to-case basis. And by and large, when we are considering debulking surgery in non-functioning tumors, we really have to be very, very cautious there when we are offering surgery to these patients.
Done for local symptoms, not for for any.
And more so when the grade becomes higher, the lesser the advantage of doing the debulking surgery, because that's where you know that these patients are not going to do that.
Is there any role of, means just for the students' sake, is there any role of liver transplantation in these kind of tumors?
Over a period of time, I think there is some evidence beyond what you have shown, but the criteria which have generally been used for considering liver transplant is generally that the disease should be G1, G2, there should be no extrahepatic disease. The disease should not be resectable as well. It shouldn't be like it's said that more than 50-60% of the liver is involved, or probably a lot. There would be a lot of play between how the liver function and the volumes are, and somewhere along the line, I think basic child's assessment of the patient, the liver function test, the albumin, the bilirubin, the INR, that is going to play a lot of role in assessing whether this patient is a candidate for resection versus a transplant.
Right.
And generally the criteria for 6 months, you mentioned 1 year, then lots of people take criteria as 6 months stable disease, progression-free disease, where they would consider liver transplantation in these patients. Right. And definitely not for more than, it will be like grade G1, G2, not for G3.
So liver transplantation is for unresectable kind of tumors, not for this category. So what is the role of so Dr. Amrinder, again, like if suppose surgery is not an option, so still you will consider same order of agents like long acting somatostatin analogs, or will you send these patients upfront for PRRT?
I think as far as trials and evidence is concerned, functionality or non-functionality was not a component of PROMIT trial, which examined the role of octreotide. So functionality is of no importance when you are using these drugs. as we see, the treatment of neuroendocrine cancers, neuroendocrine tumors have generally evolved as per the lines of small cell lung cancer. So if you think of this particular case, this is of esophageal in origin, so we don't really have these much trials. Everolimus, as I said earlier, everolimus after Radiant 4 was found to be better in thoracic endocrine tumors, lung neuroendocrine bronchial
This
cortical.
was pancreatic neuroendocrine tumor, basically. It was.
So I think PRRT, although we don't have as much, not very strong data as of now in upfront settings, still PRRT would be a good idea. However, if we take an analogy from pancreatic neuroendocrine tumors, CAPTEM will also be a good idea. Particularly, CAPTEM has shown a good response rates in pancreatic cancers.
For
If you compare
grade 1 also, for grade 1, do you recommend CAPTEM?
Because it is, sometime in the disease course, you would definitely require all these treatments. But
right. So maybe if there later on there is a means like progression in the terms of change in grading, actually, like more aggressive tumors, we can use these chemotherapeutic agents. So again, like
Dr. Manish,
yes.
So I would not give PRRT in this patient in this setting because he's a young patient, largely asymptomatic. The volume of tumor is not is not very large, and I would definitely follow. And with a grade 1 tumor, I would definitely follow up this patient, and only if there is any evidence of significant progression, either clinical progression or radiological progression, would I think of any PRRT.
As told by Dr. Mangla also, observation is definitely one of the options.
One of the options which, yeah. So the intent to treat has to be very clear in this.
And second,
I think somewhere along the line we would be surprised to see many of these patients developing very small lesions, progressing very slowly, and keeping on doing very well even without any treatment. And that's an extremely important fact that we have to remember, as Dr. Ishita very rightly pointed out again, that you will have a subset of patients in whom probably, but Dr. Amrendra also said, going on to very aggressive treatments may be counterproductive actually, and rather these patients could be observed, and if they progress at that point in time, to offer the more aggressive treatment, because as Dr. Manish also pointed out, quality of life, cost, the toxicity of treatment, all have to be factored in somewhere along the line when we're planning treatment for these patients.
So so to summarize, for debulking, basically for functional tumor it has got role, for non-functional tumor less role, for grade 3 tumors there is no role actually. So coming to case 3, grade 3 metastatic resectable neuroendocrine tumors. So Dr. Amrendra, so these tumors are actually aggressive tumors which are already grade 3 tumors, already metastatic. So what do you recommend? What kind of chemotherapy? You are mentioning about CAPTEM. So what will be your approach in these kind of tumors? What kind of chemotherapy will you give in these patients?
Yeah, of course. Grade 3 tumors are not that, avid tumors for PRRT. And as far as chemotherapy is concerned, we have good molecules in the form of CAP plus TEM, capecitabine plus temozolomide, whose response rate is well above 30%. If you compare it with everolimus, which is roughly around 9%, and sunitinib, which is roughly around 5% or 6%. Having said that, somatostatin receptor, somatostatin analogs would also be a good option, particularly if tolerability and at least tolerability is concerned. So CAPTEM is a good idea, and somatostatin receptor analogs would be another good idea.
Right. So, so like CAPTEM, is there any what kind of chemotherapeutic agents you use? Like CAPTEM always, or other chemotherapeutic agents depends upon.
Yeah, that may depend upon. Actually, if we look at Chi-67, so if it is a grade 3 well differentiated tumor, and if we use CAPTEM, and if we use chemotherapy, it has been seen that these tumors may not respond very well to treatment. However, their longevity survival is more. And if the Ki-67 is more than 55%, then they may respond very well to chemotherapy. However, their survival would be less.
So what chemotherapy will you use if Ki index is more than 55?
Neuroendocrine carcinoma and more than 55%. Sometimes we use platinum-based chemotherapy also.
Right.
Like platinum plus etoposide. So that is also one of the options if it is Ki-67 is more than 55.
Next thing actually is like Ki index. If more than 55%, we can use platinum-based chemotherapies. If it is less than 55%, CAPTEM is a good option. Both the drugs are oral agents, so it easy to use also. So Dr. Puneet, these G3 tumors, do you like to offer them surgery at any time of the treatment, like maybe after neoadjuvant chemotherapy, or downsizing, or maybe if the lesions responds very well to chemotherapy?
So yeah, I think those would be the it's surgery would be actually not the best option in G3 by and large, because they tend to be almost as aggressive as the garden variety of adenocarcinomas.
Yes.
But the kind of patients you outlined, that if there is a response, if we can biologically select them, select out those ones, those which, you know, in the some of the lower, not more than 55, but lower ones, where you can use PRRT as well, and there is some response there. Only in the biologically well selected ones would surgery be useful. Otherwise, the recurrence rates would be very high indeed in these.
Yes. So neuroendocrine carcinomas, usually we do not recommend surgery, but yes, one category, well differentiated G3 tumors, if they respond very well, then there is a the option is still open of surgery after.
And another situation, if I may add, is when you have a patient who's got a symptomatic primary. So this patient starts having bleeding from the primary.
Yes.
You have a patient who starts having obstructive symptoms from the primary, even irrespective of the grade, irrespective of the disease burden. If there is significant symptoms from the primary and the patient's surgical risk is not prohibitive, this is also a group of patients wherein even with a G3 tumor, you could achieve local symptom control faster with the surgery than any other form of therapy as well.
Right, rightly said. So I'd like to summarize this. If it is G1, G2 tumors and type 1 type of our liver metastasis, then resection is resection if it is possible. That is the best treatment. If surgery is contraindicated, other ablative methods. For type 2 kind of liver metastasis, when there is one dominant lesion with the smaller lesions in other lobe, either we can do one-step surgery, major liver resection plus RFA of the other lesions, or two-step surgery as told by Dr. Puneet earlier. And if surgery is again contraindicated, then we can go for other medical agents like told by Dr. Amrendra. And if it is type 3 tumors like diffuse multifocal tumors, in these patients only liver transplantation in selected patients is an option, but not for any other category. And for G3 metastasis, mostly it is non-surgical management by chemotherapy. Thank you very much.
Yeah, thank you, Dr. Manish, for a very nice and elaborate panel discussion on all types of NET. So, Dr. Sanjeev, are you there? Dr. Sanjeev? Okay, so Dr. Manish, you can ask the questions in the chat box from the panelists, and then we can, I think Dr. Nikhil can conclude. So there are a few questions.
Let me see first. Yes. So Dr. Shafali has initially asked, can grade of the neuroendocrine tumor can be predictive on the basis of SUV value of already been answered that higher grade lesions are more FDG avid and lower grade tumors are more Dotanoc avid. And
so Dr. Roshni has, I think, asked, how can one assess the response to PRRT, especially if the patient still has symptoms? So Dr. Ishita, would you like to answer that?
Like in all cancer treatment, you look at all three aspects. You look at clinical response, you look at biochemical response, and you look at imaging response. So with the clinical response, of course, the clinical symptomatology, where the patient is, what is the quality of life, gaining weight, etc., pain, reduction in pain, all these things. Then in chromogranin levels and 5-hydroxyindole acetic acid levels. These are maybe markers, although they are not very foolproof. There are a lot of they are fraught with a lot of errors because of various things. So it has to be done properly of PPIs for 15 days and everything. And then, of course, the radiological techniques. So if you have measurable lesions, then using the RESIST criteria is a good method. The reduction in Dotanoc uptake, while it is taken as a surrogate kind of response method, it has to be taken with a pinch of salt, because there are so many times that there is a de-differentiation of these tumors, and these tumors actually become poorly differentiated, and you find that the Dotanoc uptake has reduced, but the tumor actually is growing. So it has to be taken in consideration with everything else. And so these are the methods of assessing response to PRRT.
Probably that would be the indication for the dual tracer again, because
Yeah.
if now we are getting FDG avidity, it would be a very poor candidate for subsequent PRRT.
But funnily enough, I have seen in my experience, although I mean, irrespective of whatever textbooks say, some of these patients who actually end up with de-differentiated tumor, they don't even express FDG. So you end up with a tumor which doesn't, which doesn't take up anything, and you are. It's quite a. Some of these neuroendocrine tumor, treating them is very frustrating. So it's a very, we still don't know enough about these tumors to actually predict. So I think it has to be taken in with a holistic kind of a.
No, the point I was trying to make was that PRRT should be reserved for those where the FDG is is concordant with the PET DOTA.
Ideally, PRRT should be done in patients where FDG is negative.
Yeah, or if at all it's there, because we find we do it.
Yeah,
used to do it routinely, both dual tracer routinely to see whether there's going to be, and quite a few of them do tend to be. So that chart is not always valid.
Yeah, so it has to be. So you have the PET-NET score, so it should always be in favor of the
absolutely
the Dotanoc. So
that's the point.
Yeah,
that's the point I was trying to make.
It should be higher than the FDG uptake.
So if you have discordant,
right.
If FDG is showing discordant lesions outside the ones which are avid PRRT, somatostatin analogs, all of them will fail.
And it can be given in such situations. That was one point which I wanted to make. Even in patients who've got a higher grade tumors, sometimes there is a lot of heterogeneity of tumors, and in such situations you can give PRRT along with the targeted chemotherapy. So the targeted chemotherapy,
right.
we've actually given it with, I mean, there are studies where they've used it with Captem, used it with everolimus, with sunitinib. So there are a lot of, depending on where is your organ of origin. So there is now a lot of data coming up on PRCRT, which is peptide receptor chemotherapy. So you do a combination of therapy. So it's like doing a concurrent CCRT, so it's, you look at the radiation from PRRT and you give the chemo from the targeted. So especially works in patients where there is heterogeneity of tumors.
Yeah, in that case, I mean, we generally use capecitabine along with PRRT, because combination of Captem is little, toxic in the point of view of toxicity terms. So generally use capecitabine along with that.
It depends on the patient, how far pre-treatment, what is the
patient's
performance status. We use it in Captem in pancreatic, and usually capecitabine only in the gastroenteric neuroendocrine.
So Dr. Lovkesh, you can take the last question.
For temozolomide, there's another, actually, when you're talking about personalization, you can actually look for MGMT, methylguanine methyltransferase expression.
Right.
Select out the patients, to reduce the toxicity of temozolomide.
Also, temozolomide being an alkylating agent, there is a higher risk of
myelosuppression
when you use it with PRRT. So that is something which we need to take into consideration, especially when we are dealing with patients who are who have a potential of a long survival, younger patients. So these patients, we should be a little cautious about using alkylating agents along with PRRT.
Very true. And Dr. Lovkesh, you can take up the last question. So what first investigation will you do after CT when you suspect a neuroendocrine tumor?
It depends. In CT, we have identified the focus or not.
So you have identified a focus, and then how do you, I mean, if you suspect a neuroendocrine, what next best investigation you should go for? Diagnostic purpose.
It depends on the site also. So as I told earlier, also endoscopic ultrasound is now the best modality for grading and staging both. So because with it we can detect the size, the depth, whether it has involved submucosa or the muscularis or the other deeper layers, the loco-regional metastasis also. And now with the advent of new needles, we have now 19 gauge needles with which we can take the biopsy. And since this is more nearer to the lesion, so the chance of the tumor spread is also low. So we can give the pathologists what they usually require for this Ki-67 staging. So with that, they can help in grading. So if we have identified, then of course this endoscopic ultrasound. Other uses of this endoscopic ultrasound for the surgeons, the newer thing is we can do the tattooing. We can tattoo the area if it is a smaller one, so that they can identify that the resection area would be less. Yeah, but if it is not identified, then I would say that the protocol is that we do the endoscopy, colonoscopy, and if we suspect in the intestine, the small intestine, then if it's not a structuring lesion, then we can do the capsule and vis-a-vis the enteroscopy, although still a matter of debate whether we should go for that.
Correct. Right. So Dr. Nikhil, now I think we should conclude. It's over to you.
Yeah. Thank you, Dr. Shefali, and thank you, everyone. Thank you very much. It was a very, very comprehensive discussion, and I think it would be very helpful in clearing the doubts of students. And next, we are talking about metastatic neuroendocrine tumor, mostly the medical oncological and the theranostic aspects of that. So with that, I would like to conclude. Thank you all. Thank you very much.
Thank you.
Thank you.
Thank you.
Yeah, thank you so much, all of you, for joining. Thank you.